Hi, and welcome to my podcast, the Fertility, Motherhood, and Wellness Show True Stories with Dr. Rajeev. Through this podcast, I will be dealing with issues related to fertility, safe motherhood practices, as well as women's health. So, hi, friends, here I am back again with yet another topic. Some listeners have commented that I tend to shock them in my podcast. But yes, the information is very, very comprehensive and compact. Thank you. So, is that the best combination possible to shock you as well as give you all the information? Sometimes a little wake-up call is what all of us need to realize that there is a problem and that it could be big. I do try and collate all the information that I can from all the scientific sources, including my limited brain, and put them together in my podcasts so that you don't need any other resource for that information. It is the most powerful creation to have life growing inside you. Yes, there is no greater gift. And it is our collective duty to be aware of issues that can harm you or your baby during pregnancy and move heaven and earth to avoid those complications. India is dubiously known as the diabetes capital of the world. Thus, it is only logical to assume that there will be many women who will be pregnant and will also be battling diabetes at the same time. The topic of my discussion today is battling blood sugars in pregnancy, and in the next few minutes I will be discussing the testing, treatment, risks, and exactly how it might affect you and your baby. Before I move forward with statistics, I must explain 4 terms to you. Type 1 diabetes. This happens when there is little or no insulin production by the pancreas. More common in adolescents or younger people and has no correlation with lifestyle or diet, meaning you can't do anything to prevent this. In type 2 diabetes, there is insulin, but either it's less or it's ineffective. If you are an Asian or have a family background of diabetes, or are above 40 years of age, or obese, you will have a higher chance of developing this. Gestational diabetes. This happens for the first time in pregnancy because the changing pregnancy hormones cause insulin resistance. That is, the insulin is present but less effective. This sets in usually around the 6th month of pregnancy. The women at higher risk of developing gestational diabetes are short women or women who already have glucose intolerance before pregnancy, women with polycystic ovarian syndrome, those with age above 35, overweight or obese, women who have a family history of diabetes, or they have had gestational diabetes in one of their previous pregnancies. Women with excessive weight gain in pregnancy, or those that had vitamin D deficiency in the first 3 months of pregnancy, or those that develop higher blood pressure in pregnancy will also be at a higher risk. Thus, your past, present, and future affect your chances of developing gestational diabetes as you stand pregnant in the first few weeks of the journey. This brings us to the last term, that is, glucose intolerance. This is a term which is applied to those people who are not frankly diabetic but sort of pre-diabetic. Imagine me standing at the edge of a cliff, perfectly balanced. But if you were to give me the slightest of a push, I would fall over. These women too exhibit normal values of sugar when tested either in the fasting state, but when they are given a glucose load, their sugars go over normal limits. Why is it so important for us to know about them? These women will develop gestational diabetes much earlier than 6 months into their pregnancy, probably even in their early pregnancy. And thus, this cluster of women need to be discovered to avoid complications. I understand you must be wondering by now, am I trying to make a doctor out of you by teaching you meaningless jargon? Or is this part of my scary routine? Worldwide, Less than 1 in 10 women have problems with sugars in pregnancy. Not a big number. In India, the incidence varies from 1 in 10 to 1 in every 3 to 4 women, depending on which part of India you belong to. And that's a scary number. Of all the women who battle blood sugars in pregnancy, about 1% are type 1 diabetes, 9% are type 2 diabetes. I've already explained these two terms before. And the rest 90% are gestational diabetes. Okay, so now we understand the problem is common and it's commoner in India. So, what's the big deal? Let's first understand what it means for the mother. 12% of such women will develop blood pressure in pregnancy because of the elevated blood sugars. So one problem leads to another. 10% of women with gestational diabetes will develop blood pressure after delivery, and this will require lifelong treatment, so the problem never goes away. 50% of women who have gestational diabetes will develop type 2 diabetes within 5 years of childbirth or after the age of 40. What does it mean for the child? Mothers with pre-existing diabetes have a miscarriage risk of 12% as compared to normal miscarriage rate for all other women to be about, say, 2.2%. If the diabetes has been around for more than 10 years, or with a poorly controlled diabetes with HbA1c of 11% or more, I will explain HbA1c just a little later, the chances of miscarriage increase to 44%. That means almost half of the babies will have problems. Increased risk of heart and brain, spinal cord, nerve and other defects are going to be common. HbA1c is a blood test which tells us how good the sugar control has been in the last 3 months. The normal value should be less than 6.1% in the beginning of pregnancy. For every 1% rise in HbA1c above 6.3%, the risk of abnormality also rises by 30%. And the risk of problems is almost 44% if the HbA1c goes beyond 11%. These figures are confusing, I know, but they're important to impress upon you the fact that sugar control in early pregnancy is of paramount importance if you wish to prevent defects in the child. Macrosomia or big babies? That's the next problem. You have often heard of families jumping with joy when someone delivers a big, very heavyweight baby, little realizing that most such babies are born to mothers who had undiagnosed, uncontrollable sugars. Lesser chance of a normal delivery or a higher chance of an injury during delivery because of the big size also happens if the baby is big. Lastly, and in quite a scary manner, women are at higher risk of babies dying in their mother's womb in the 3rd trimester if the sugars are not well controlled. And mind you, even after the baby is born, the problems don't cease. There is a higher risk of dangerously low sugars in the baby, respiratory problems, jaundice, and low calcium levels immediately after being born. There is a higher risk of obesity, blood pressure, and diabetes later on in life. And the intelligence quotient of these babies later in life is also lesser than the others. So if the problem is indeed so common, serious, and with far-reaching consequences, how do we deal with it? Now I see I have your attention. Golden rule is making sure you have a preconception counseling done before pregnancy to know your existing problems. Blood sugars become more relevant and important if you have risk factors like obesity and polycystic ovaries and other factors as mentioned at the beginning of this podcast. If you are found to have sugar issues, please get it sorted before you conceive. Once pregnant, one must remember that merely doing a fasting blood sugar test or doing a simple post-meal test is not good enough, because this way we miss those who have glucose intolerance. Take 75 grams of glucose, a simple Glucon-D as sold in the market, on an empty stomach, and without eating anything in between, give blood for sugar estimation after 2 hours. the value should be less than 140 milligram per dl. If the value is quite below this level, we are good and you're safe. If the value is only slightly below this level, then you need to be careful. Make sure you engage a nutritionist and exercise regularly. If the value is more than 140, speak to your doctor and he or she will guide you best by creating a team with a diabetes specialist and a nutritionist, and the three of them managing the problem together. Even if the values are normal, those with higher risk should get this test done few more times in pregnancy. As I said earlier, gestational diabetes normally sets in after the 6th month of pregnancy, and thus we repeat this test at that time again for each and every patient. Depending on the values, the line of management will be the same as I mentioned before. Another question I keep getting from patients and even doctors is that once a woman is diagnosed to have sugar issues and she has been put on a diet, on medicines or even insulin, how do we monitor the sugars? Unfortunately, there is a lot of confusion in many minds regarding this, but if one were to go by scientific guidelines, the advice is very clear and simple. And mind you, the advice is different for pregnant women as compared to those in the non-pregnant state. So you can't go by what your general physician has told you as to how sugars need to be monitored for any other adult or elderly person and someone who's not pregnant. Test your blood glucose levels by a finger prick using a home glucose meter 90 minutes after breakfast, lunch and dinner. All values should be less than 120 milligram per dl. Remember, after breakfast values are the most notorious for going up, so watch those more carefully. Before I end this podcast, 3 more things you must remember. 1. Such women are at a higher risk of urine infections, which in turn can lead to premature delivery. Keep a watch out for the infection by getting yourself tested frequently. They can sometimes be silent. 2. Babies born to such mothers are notorious for having respiratory problems, even if the delivery happens close to full term. 2 doses of steroid being given largely takes care of the problems and makes it safe for the baby. Do not hesitate in discussing this with your doctor and taking the injection even though it may temporarily raise your blood sugars further. Point number 3, lastly, the sugar levels will drop to normal within hours of you delivering. Thus, you need not worry about continuing medicines or even insulin after birth. But yes, you need to change your lifestyle later to avoid it coming back into your life permanently. Remember, your pregnancy goes by fast. Enjoy every moment of it, but enjoy it responsibly, because you have the world's future in your womb, and I have the responsibility of that future on my shoulders. This brings me to the end of yet another podcast episode. I hope you enjoyed listening to it as much as I enjoyed making it. If you get a chance, do look up my website www.drrajeevagarwal.co.in and the associated blog. I also have a YouTube channel in my name. Do email me on fertilitywithoutborders@gmail.com if you have any queries or if you want me to create a podcast on any topic of your choice. This podcast is available on Apple and Google Podcast as well as on Spotify. Do subscribe and leave your comments and suggestions on the Apple Podcast app, because that's the only way we can make this better. Looking forward to great interactions. Keep listening.